healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Welcome everyone, this is Stuart Newsome, and once again, I am flying solo for this particular episode. Today, we're diving into a critical and fast-moving issue, and that is how AI is transforming the healthcare revenue cycle, not just for providers like you, but also for the payers that you work with every single day. So yeah, everyone's saying, we already know that. We already know that AI is transforming healthcare. So what's the big deal today? Well, we're going to focus mainly on payers. We're also going to focus mainly on the compliance side. So we're going to get into that a little bit here in the preface, so to speak. So our title today is Staying Ahead in the AI Arms Race with Payors. And it isn't just clever wordplay. It reflects what's really happening right now in the real world. Payors are building massive AI infrastructures that influence claims adjudication, denials, utilization management, even recoupments. The providers having to respond, often reactively, with tools and processes and governance on their own. And many times it's kind of where do we turn? I know there's a lot of vendors out there, there's a lot of consultants out there, because AI has been around for many, many years now, and it's a vastly evolving at a great speed. I mean, we're doing things today that we couldn't do 6 months ago. And I've been in healthcare for about 30 years now, and I've seen a lot of changes, particularly in technology. And I've never seen the pace that we're at right now, particularly with AI. Now, you may recall, I went over a recap of some of my takeaways from attending the AAPC HEALTHCON conference that was recently held in Orlando, Florida, in a previous office hours. That was a couple of weeks ago. And if you subscribe to our Revenue Cycle Optimized podcast, you may have caught an episode where I interviewed some attendees while we were there on site and giving their opinions regarding AI, as well as a couple of episodes where I took some excerpts from a presentation I did live while I was there at HealthCon. So this session is based on that live session where we explored compliance in an increasingly automated revenue environment. So rather than replay that session, because it was about an hour and 10 minutes or so of me just talking, if you could imagine that, but I wanted to condense it. And again, we did do some excerpts in the podcast, so I encourage you to go out and catch that. But I just wanted to revisit some of the few key ideas from that talk, kind of make a version that's tailored for office hours in particular. And also there's some updates, going to give some update to some insights from some recent federal policy shifts. There are some live provider conversations I've had since then as well, and then also some emerging governance models that reflect real-time challenges in RCM. So let's walk through what AI arms race really looks like from both the payer side as well as the provider side. So we'll explore how automation is reshaping risk in RCM, especially compliance risk, and what real world government looks like even in small teams. I'll also share updates on policy from Washington and what it means for your practice. And then finally, we'll examine how providers across the country are adapting workflows and oversight to navigate this fast-changing landscape. And I'll address some of the most common questions that I hear, particularly some that I heard while giving the presentation at HealthCon, and also from leaders like you that I've had a pleasure of speaking with. So first, I just want to begin with the term arms race. It's a loaded term, but I use it deliberately. We're seeing a rapid escalation of artificial intelligence capabilities between payers and providers. Now, each side is using AI to gain speed, accuracy, and leverage. Who wouldn't, right? Is there an easier, faster way of doing things? Then I'm all for it. But only one side has regulatory immunity, and I bet you can guess which side that is, and it's the payers. So just reflecting back, let's take a look at Cigna. They had a system called PXDX, for example. This platform was able to deny 300,000 claims in 2 months. Now that averaged 1.2 seconds per review. Now that wasn't human speed, that was algorithmic. It scanned for expected code-to-code diagnosis matches, flagged any exceptions that it saw, and issued denials en masse. So Cigna did this with virtually no pre-notification for providers. Now, this was 3 years ago. Imagine that capability today. I just mentioned earlier, we've been able to do things just in the last 6 months. that we weren't able to do, 6 months ago. Imagine 3 years, and the impact that it's now having. So if they were able to do that 3 years ago, that's now escalated to a larger scale. Then you've got United Healthcare using AI to manage post-acute care transitions. Now, in late 2024, their denial rates for those transitions tripled. Providers were often blindsided. Patients approved for rehab on Friday were denied by Sunday night based on some retrospective model analysis, they like to call it. Now, Humana, they don't get off either, but by implementing AI-driven prior auth rules, they saw denial rates for acute care increase 54%. Now, I don't care, anywhere where you can see something that benefits you by 54%, what's your natural inclination? You're going to go for it, right? You're going to use that model, and that's exactly what they did. So all of this was not because of the clinical need, and I have quotations going up, not because that clinical need changed, but because the model learned how to say no much faster. So even regional Medicaid and Medicare Advantage plans are getting into the game. One plan in the Pacific Northwest used an AI audit overlay that flagged pediatric behavioral health billing as an anomalous, not because it was wrong, but because the data was too consistent. Can you imagine that? Consistency is a bad thing. So what was their logic? Well, fraud detection models are suspicious of anything that is near perfection. So if you're doing it right, they must think you're doing it wrong somewhere. And that is the case. I've seen that again, 30 years in the business. I can remember even, 20, 25 years ago, that was the case. You got flagged for an audit, even if you had progressions of success, progressions of improvement of your revenue, they were going to come and target you for audits. So when we say arms race, this is exactly what I mean. The providers are arming themselves with that speed, scale, and automation, and it's all on the payer side, and it's transforming the economics of claims. And providers are being forced to match that speed while staying compliant. Now, the almighty payers, they have a lot of money, they have a lot of power, and they have a lot of data. Now, we're going to get into that a little bit more in detail, but that's what really matters here. They're able to crunch decades of data and look at frequency. And now they're able to do it much faster. Before, doing it the old-fashioned way, yes, used computer algorithms, but AI is escalating that at the speed of light right now. So initially, most providers saw AI as a tool for operational efficiency. We're in the AI business, a lot of other vendors in the AI business. I have conversations with a lot of providers, a lot of groups, a lot of hospital executives, and they essentially are see the necessity of getting AI. But their posture towards that is more about automating speed, accuracy, leveraging efficiency, things like automating insurance verifications, speeding up prior auth submissions, scraping PDFs for intake, categorizing documents. And these were helpful, no doubt, but they were the low-hanging fruit, so to speak. What we've learned is that as soon as those systems start touching decision making, like coding levels, medical necessity, documentation standards, the risk profile totally changes. So automation becomes accountable, and now compliance and audit professionals are in the loop. Let's just say you're using AI tools to flag undercoded visits for review. I'm picking on this because I used to do a lot of E&M audits in the past, and so I understand the need for the dangers of undercoding. Certainly there's a danger in overcoding, but there is always been a huge problem in undercoding your E&M visits out there. So what a great way to use AI, something that can trigger and look at those instances where there is undercoding determinations and then correct it before it goes out the door. All sounds great, right? But what happens when it consistently overcorrects? You submit claims at a level 4 that should be a level 3. Maybe payers don't catch this at this month, and they certainly, let's go back maybe a couple of years ago, they weren't catching it very quickly. But now, maybe 6 months later, they retroactively claw it back because now they have the capability to look at it in mass. But who's liable? Is it the AI that's liable? Is it the AI agent that's liable? Still the provider. You are liable. So another example here is your AI extracts some clinical details from a referral form and then auto generates a prior auth submission. Sounds great. But the payer changes the coverage policy and your model hasn't been retrained yet. So the auth is denied, the claim is delayed, and now your denial team is trying to fix a machine-made error that no one saw coming. Now that doesn't have the same repercussions as, say, overcoding, where there's a recoupment of payment, or even worse, maybe even civil penalties if there's a pattern of fraud and abuse that can come to that. But still, there's this extra layer of work. There's more you have to do now to go back and try and figure out what happened. And once you figure out what happened, solve the problem. Okay. So these situations aren't theoretical. They're real world examples that are actually occurring today. So the lesson is this: you can't separate efficiency from compliance anymore. If a machine makes a decision that affects reimbursement, it needs oversight. If a machine makes a decision that has some clinical decision involved with it, it definitely needs oversight. It needs explainability and it needs accountability. So let's talk about governance now. That's not really a buzzword, but it's a set of real tangible actions and what your team needs to do to be sure you take that action in place. And I stated this while I was at HealthCon. Being a CPCO, I kind of gravitate towards compliance in that circle. So hanging out with some of my fellow compliance officers, it was, how their take on AI was coming about. They really embraced it, but they had more questions than answers about accountability and how this is going to come about with making sure there's safeguards in place, because there needs to be that accountability. And most practices, most large health organizations already have a compliance committee. So I'm not saying create a whole separate committee. You probably already have this committee in place, but you need some type of AI governance that's a part of that committee. So when I say AI governance committee, I'm not necessarily say create a new committee, just add another layer that needs to include AI. You need to treat it like another employee, treat it like another process that needs that oversight. So it doesn't really matter if you're a 10 hospital system or a 10-person practice. The size of the group can vary, but the roles can't. So these include compliance and privacy officer, of course, maybe a revenue cycle leader, maybe whoever's heading up your RCM, whoever's heading up your billing, whoever's heading up your denials. For that reason, you need someone in compliance who's going to make sure you're up to the regulations. And for AI, there's very little, but we'll get to that in a minute as well. For revenue cycle, those are the ones who are going to understand what needs to be automated, how and why, and what you need to watch out for if things go wrong. You obviously need a clinical stakeholder as well. Clinicians are very important. It could be, say, a medical director. It could be a physician on the team that has that insight, and obviously someone from IT and informatics to make sure it's all going to work well. And also, and not any lack of importance here, but also an executive sponsor who can advocate for everything going upward. Someone who can remove any of the obstacles that get in the way from moving forward. Because we all know if anyone's ever been on a committee, there's always obstacles involved. So you need someone who can just, blow that up, so to speak, and get things moving. So their job is to evaluate AI tools before implementation and approve any workflows, monitor outcomes, and manage any incidents that come about. So every new tool should come with a test plan. I know many of you probably have already experienced perhaps purchasing or implementing some type of AI within your workflows already. It's always a good practice to test that. Perhaps maybe have a trial, maybe have a pilot, if you will. So before go live, you run it in parallel with your current workflow. So, and then you document the results. You document if there was any false positives or false negatives, and then you track any of those exceptions. Once the tool is live, the committee sets basically a cadence. It can be monthly, it can be quarterly, depending upon how comfortable y'all are with it, and also depending upon the risk that came from that trial. You review those key performance indicators. Everyone has KPIs. Well, guess what? AI needs to have KPIs as well. And do those KPIs rates, match between AI and human decisions, the error volume, the override patterns, and appeals triggered by AI generated denials. And it seems that AI, from what I've gathered from some discussions at HealthCon, is kind of getting more leniency when it comes to KPIs. They're getting a free pass, if you will, in some cases. I even spoke to one coder in particular that they had set up where the AI had to be accurate 85% of the time, when her KPI was to be accurate 95% of the time. So when the AI has to be a little less lenient and be right 85% of the time, she thought there was something wrong with that. So there's always varied opinions and a competitive nature, which never leaves the human spirit. But let me just give you an example. A radiology group implemented a tool to extract data from PDF orders. At first, accuracy was high, but over time, exceptions kept creeping in. Forms were formatted differently. Some had handwriting, others didn't. The model wasn't adapting. But because their committee had baseline data from testing, they noticed the drop. So they paused automation, they retrained the model, they looked at some of their processes, how this change needs to be effected, little course corrections, if you will, and then they resumed after all that validation took place. Now that's governments in action. Now, while the CHAI, and I'm going to get to those acronyms in just a few minutes, but right now, let's just call them the CHAI, offers industry guidance for this. Let's not forget the evolving role of the federal government and state regulators in shaping healthcare AI policy. Now, if everyone will recall, if you're paying attention to the news, in late 2023, the Biden administration issued Executive Order 14110. So I'm giving you these executive orders so you can go look them up yourself. We could probably do a deep dive into each one of these if we need to, but we just don't have the time or bandwidth. But this executive order outlined the federal government's first broad strategic framework for responsible use of AI. And that order specifically tasked HHS with developing AI guidelines for healthcare, emphasizing equity, civil rights protection, and auditability. Now, the core message there was that AI can be transformative, but it can't be a free for all. Now, fast forward to 2025. As we all know, the Trump administration overrode a lot of executive orders, but he took a different path with Executive Order 14179. Now, this updated directive leaned more aggressively into fostering innovation. And I'm all for innovation. I'm all for guardrails. I'm all for innovation. We needed something that kind of go between these two. But instead of primarily cautioning against AI misuse, it focused on removing any barriers to implement and accelerate federal agencies on adoption of AI tools. Now, while compliance guardrails remain part of the discussion, the spotlight has shifted to speed, scale, and global competitiveness. Now, what does this mean for you as a provider? Well, it means that the federal policy is still in flux. One administration emphasizes guardrails and the next acceleration. Now, without specific enforcement mechanisms tied to either one of these executive orders, the onus continues to fall on the provider organization to self-regulate. And we know you can't do it all by yourself. That's why you need experts, and it's just a slew of vendors that are out there just chopping at the bit, knocking on your door, I'm sure. But you just need to evaluate that advice very carefully, which I'll get into in just a second as well. But also, that's why at the state level, actions are so important to track. Particularly in California, they've already introduced laws mandating that AI systems used in clinical decision making be auditable and explainable. Colorado as well similarly now requires insurers to report AI error rates when used in utilization review. And this is a good thing. So these states' mandates are often more specific than anything we're seeing at the federal level. And that tends to be the case with a lot of regulations. A lot of mandates go out, the regulations then soon follow, and it's kind of a trial by error. And some things we're still working out with regulations when it comes to certain CMS mandates. So it's just kind of school of hard knocks, if you will, and then we all eventually get there. It's not ideal, but it seems to have worked in the past. So I don't expect anything less regarding AI. We're much further along than we were, say, 2 or 3 years ago. And then there's the global angle. You look at it from a world view, particularly the World Health Organization has published position papers calling for transparency, fairness, and safety in healthcare AI deployment. Kind of mirrors what Biden was talking about. So while these guidelines are not binding, they're beginning to shape how multinational health systems and vendors approach AI governance. Now, meanwhile, the Coalition for Health AI, remember those acronyms I referenced earlier, the CHAI? Well, that stands for the Coalition for Health AI. And they're playing a pivotal role in filling the policy gaps. So CHAI is an industry alliance that brings together health systems, academic research centers, technology companies like Infinix to develop concrete standards for trustworthy, responsible AI in healthcare. Now, as reported by Modern Healthcare, their work focuses on building frameworks around fairness, explainability, data integrity, and patient safety. All sounds familiar. Seems like all of these groups and goals and everything I've just read off have the same goals in mind, but they need to come together and have something that's really mandated. So it's really more like you can piece it together, patch it together, and see what those guidances are. But these voluntary guidelines from CHAI are already influencing procurement decisions, even tool design, product design, as well as any institutional policy that's out there. So while CHAI doesn't have enforcement authority, it's rapidly becoming the de facto blueprint for those who don't want to wait for regulation before implementing oversight. Now, let's continue with some real world adaptations and how providers are putting these ideas into practice. Now, you take a hospital system in the South, created a living document called the AI Utilization Register. Now, I really like this idea. It tracks every AI tool deployed across departments, from prior auth to coding to patient scheduling. Each and every entry includes the tool's name, the function, the vendor, what version number, performance metrics, and even an audit schedule to go back and review it. It's reviewed monthly by the compliance team, that governance team committee I was talking about earlier, and helps prevent any rogue tool adoption. So again, there's those guardrails. Now, in contrast, you take a specialty surgical group in the West Coast, took a more tactical route. They created a playbook of the 6 common AI errors they had experienced, like mismatched payer policy mapping or misinterpretation of clinical notes, and trained their billing staff to flag these. Now, I want you to notice something. It's the human specialists, the billing staff working in tandem to watch over the AI. They called it their AI pattern spotting guide. And that's not some fancy name they made up. That's just what they call it. Now it's stuck. Now, since launching it, they've reduced post AI error rates by 40%. That's not bad. Now you take a behavioral health provider in the Midwest. They implemented a hybrid model for prior auth submissions. The AI prepares the form, attaches relevant documentation, and queues it for human review. The reviewers give it a confidence rating, so to speak, and if it's above 90%, it's sent automatically. If not, then it's edited. Now, that rating system becomes a part of the audit trail, helping them trace errors and retain the model. Now, again, a multi-site radiology group runs a quarterly vendor summit, so to speak. And this is a pretty cool idea as well. It's kind of like a QBR, a quarterly review, but it's a bunch of vendors coming together under this AI umbrella. So every vendor with an AI touch point within their organization joins a virtual meeting with compliance and operations staff. And then each presents error rates, support tickets, update logs, and upcoming changes. It's part of a performance review, part of the roadmap preview, kind of a mix of both those. The structure keeps vendors accountable and builds a collaborative ecosystem. Now, across all of these, the common thread is intentionality. Providers are asking, what is the tool doing? How do we know it's working? And what happens when it doesn't work? So, with that said, you can see there's a lot of accountability involved. You probably noticed that there was a theme throughout that it does require human intervention. I know a lot of people think of AI, it's, oh, they're going to take over. Some think, oh, please take over, set it and forget it. But no, it still requires human intervention, human oversight, even human and AI working hand in hand to try and accomplish the goals that are set by the organization. So with that, I'm going to shift to a few questions that I have heard frequently over from other healthcare leaders on how and what makes sense of AI adoption. So one question I got was, well, how do we measure the effectiveness of AI tools beyond just speed? Well, speed is, when I respond to them, I say, well, speed is very seductive, but is it sufficient? And my answer is sometimes it's insufficient. You start with precision and recall, like how often does AI get it right and how often does it miss? And then you look at the business impact. Does it reduce denials? Has there been any improvement in your net collections? Do you lower your days to authorization, add staff capacity, match metrics outcomes, not just activity? So for the sake of, sometimes we get away with quality for the sake of speed, but I think quality is more important first, then you wrap up, and then you can get faster and faster the more you do it. Another question I get is, how do we justify the cost of governance to leadership? And this is a good one. This is a little different than ROI, but it's the cost of governance, which is that intangible. You have a lot of people's salaries, you have a lot of time invested. You may even have some tools that you have to dedicate to this. So how do you get that across to them? Well, think about the cost of rework, denials, or failed audits. One mid-sized practice estimated they spent $4,000 per month in denial rework due to the misconfigurations of AI rules. So you multiply that across departments. So government isn't overhead, it's loss prevention. And then lastly, we have, well, what should we require from AI vendors at the RFP stage? Well, you need to ask more than just a demo. You need to require maybe some sample outputs, ask for explainability documentation, get any error logs, ask what retraining looks like, who is responsible for fixing any of the issues, what's the support SLA, what does that look like, and get it all in writing if a vendor can't really give it to you. And these are all tactics that you likely already have in place. It's just now you're actually applying it to the AI and to those vendors that have AI. So with that, I'm going to see if there are any other questions in the chat. So one more question that I see here. Yeah, and I get this quite a bit as well. How do we help staff trust AI tools more? Well, you start with education. So the first thing is they need to understand that AI is not the enemy. AI is not going to be coming in and taking over, but it's there to be used as a tool, and explain it as just that. Explain what the tool does and what it doesn't do, especially what it doesn't do. Show how it's monitored, share the audit results. And this is key. You need to involve them in the test phase, involve them early on and get their input and see how decisions are made. So trust comes from understanding as well as involvement. And that's the whole key, is when you get them to trust it, you got to get them to understand it and buy into it. And then we had one more question that popped in here. Can we use AI to monitor AI? Well, yes, you certainly can, and it's already happening. Some organizations are using lightweight AI models to flag inconsistencies or outliers in their large systems. One example that comes to mind is there's a group that uses QA overlay that scans for documentation mismatches between progress notes and coded services. Think of it as a second set of digital eyes, so to speak. But even if you have AI monitoring AI, well, someone's got to monitor the AI that's monitoring the AI. So eventually it does come down to human intervention, human specialists still involved. You can have systems where a certain percentage of the work that AI is doing is going to be in a Q&A queue, so to speak, where there's human specialists that can look at that and make sure the work's being done correctly, make sure that that's documented as well, so you can track it back to your governance committee. So as we close, just want to leave you with this, and that is that AI in the revenue cycle is not a question of if, it's just a question of how. How you implement it, how you monitor it, how you make sure it serves your patients and not your processes, and particularly how you can stay compliant with it. As we've seen, and probably some of you experienced this, payers are leveraging AI to control cost and improve their bottom line. And you really can't blame them. I can't blame anyone who wants to be more efficient, more profitable, and control cost. But they're doing it in ways that are just taking healthcare systems and leaders by surprise. I'm hearing stories about how organizations are getting the recruitment letters, the audit letters are increasing because now they're crunching the numbers much faster at a much more efficient rate, and able to come back to the money and get that money that they feel like they shouldn't have paid to begin with. So providers must leverage it too. You must catch up and be a part of this to protect your revenue, but also safeguard against compliance, because that's the forgotten piece, I think, in most areas, that AI doesn't fall under compliance, but it certainly does. But it also needs to be transparent to enable to your revenue integrity and your clinical integrity. So don't wait for regulation to catch up. Build your own guardrails, create your own audit trails. In this arms race, speed does matter, but strategy is going to always win. So be sure you do carefully, but be diligent. So thank you again, everyone, for joining me today. Also, and be sure to subscribe to our Revenue Cycle Optimized podcast. Until next time, stay sharp, and we'll see you next week on our next episode of Office Hours.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's INFINX.com.